for joining us this afternoon. My name is Nidhi Hegde, and I'm the Managing Director of the American Economic Liberties Project. We're an organization dedicated to challenging consolidated corporate power across the economy and ensuring that markets are competitive and fair to working people, entrepreneurs and small businesses, and local communities. We're here today to talk about an industry with one of the most pernicious manifestations of monopoly power, healthcare, and how state lawmakers can fight back. So whether you're looking at hospitals or insurers, pharmaceutical companies, or medical supply companies, concentration in the healthcare industry is systemic. For decades, it has been allowed, in some cases promoted, by policymakers and regulators, and has now reached a crisis point. Today, any interaction with America's corporate-owned healthcare system is traumatic. Whether you're a patient who's struggling to get their prescriptions because of drug shortages, or you can get your prescription but can't afford it because the prices are too exorbitant, or you're a healthcare worker who's seen their wages cut and their hours reduced and hours raised, trying to provide the best care you can with rapidly dwindling support. Or maybe you're a family physician who's been forced to sell up to a massive corporation. Corporate power in healthcare harms patient outcomes, worker pay, and communities, oftentimes those most marginalized across the country. However, there's a silver lining and change is possible, especially when communities and lawmakers come together. And that's why we're here today. Our mission at Economic Liberties is to arm policymakers with the tools to protect the health of their communities. Over the past few years, we've helped expose the harmful practices of pharmacy benefit managers, examined how policymakers can fix drug shortages caused by consolidated group purchasing organizations, detailed the harms of hospital mergers, and even challenged hospital monopolies like the University of Pittsburgh Medical Center. Our state and local team, led by Pat Garofalo, has been firing on all cylinders, providing policymakers with the research and actionable state and city-level policy solutions so that communities can successfully address these harms. In continuation of these efforts, today we're thrilled to release the fourth state and local toolkit focused on healthcare. This follows previous successful toolkit releases for lawmakers focused on reforming state antitrust laws, reining in big tech, and taking on the corporate subsidy machine. So I'm going to hand it over to Pat now, our Director of State and Local Policy here at Economic Liberties, who will be moderating the event and introducing our esteemed guest, Minnesota State Senator Erin Murphy. Over to you, Pat.
Thank you so much, Nidhi. As Nidhi said, I'm Pat Garofalo, Director of State and Local Policy here at the American Economic Liberties Project, and I'm super psyched to be here moderating this event today. It's clear that corporate consolidation in healthcare, from hospitals to physicians' practices to pharmacies, is a growing concern for communities. In fact, over the last year at Economic Liberties, we've been asked about this area of public policy at the state and local level more than any other. So we've put together a great toolkit authored by our research manager, Eric Piner, who you'll hear from in just a bit, with a ton of practical policy steps and model legislation for state lawmakers and advocates who want to address healthcare consolidation in their own states. It's available on our website, on our social media channels, or feel free to reach out to anyone on the team here to get a copy. But before that, I'm so thrilled to introduce Minnesota State Senator Erin Murphy, one of the great champions taking on healthcare consolidation at the state level. Minnesota has rightfully received a lot of attention for the hugely productive and exciting legislative session it had this year, where they passed a host of progressive policy into law despite having just a one-vote majority in the state Senate. On healthcare specifically, Minnesota took great strides by adopting new rules to govern hospital mergers, creating a public insurance option, and banning non-compete agreements, which is going to give critical new power to healthcare workers. A former nurse herself, as well as a former executive director of the Minnesota Nurses Association, Senator Murphy has been on the front lines of those fights and so many more as a worker, advocate, and now a leader in the state legislature. She is also simply one of the best communicators and thinkers on this issue out there in any state today. Minnesota is very lucky to have her. There's still so much more work to be done, as I'm sure Senator Murphy is going to explain. We're honored to have her here with us today. Senator Murphy, the floor is yours.
Thank you, Pat Garofalo. And to everybody here today, thank you for including me in this important discussion. And I am absolutely thrilled to be a part of what I hope is the next generation of important work across the states to make sure that we're making good on our promise that everyone in Minnesota and in the states across the country have access to meaningful and affordable health care. It's a human right. I think many people agree with that, but we're not treating it as such anymore. And I think in Minnesota, while we are replete in the feeling that this last session is proven that we can make real progress for people, we have so much work to do to prepare that next agenda. The agenda that we moved last session was in some cases 20 years in the making. And we have a great deal of work to do with Minnesotans to make sure that we're hearing their voices and incorporating into the policymaking arena the things that they are asking for. And healthcare is a question that they're raising all of the time, all over the state of Minnesota. I am a registered nurse. I did for many years work for the Minnesota Nurses Association, the Union for Nurses. I started there as a baby organizer. I was a lobbyist, eventually their executive director before I ran for office. I ran for office when I took care of my mom at the end of her life. And she had terminal cancer. She only lived for about 11 months after her diagnosis. And she had to fight to get some of the care she needed because an insurance company was denying a critical medicine. And we had to fight with her, despite having really great coverage. We had to fight, and she got the care she needed. But at her funeral, my aunties all said, "It's time for you to go do something." And I decided that something was to run for office. And I will say that I was not prepared for the work of running for office coming off such a challenging loss. But I knew that I could bring my voice and the skills that I had built for so many years working for the nurses in pursuit of this care for everybody. My earliest work with the nurses as an organizer was in the early 2000s, the late 1990s and early 2000s, in the passage of something that we still have in Minnesota Care, which is a state subsidized program, a healthcare coverage program for people who don't have access to employer-based coverage. It was a novel idea, a nation-leading idea when we put it into law in Minnesota. And it was passed within a very significant framework to reform the healthcare system in Minnesota. It included two critical features, one called the regulated all-payer system, which was to capture those entities that didn't want to participate in the preferred and given preferential treatment universal system of care for everybody in Minnesota. So even then, decades ago, we were contemplating how to make sure that a system that is transcending private and public we were using our regulatory powers to drive people into a public system that would serve their needs and in their interests. We passed that into law, and within a year, the interests of the current healthcare system, those corporate interests, started taking apart the powerful tools, including that regulated all-payer market and the instruments that were driving people into a universal system. And the argument they were using is a strong public system would crowd out the important private marketplace. And in the wake of those changes that happened so long ago, as we've continued to persist in making sure people have access to coverage, implementation of the Affordable Care Act, we have seen the private marketplace driven by corporate interests crowding out the actual care of Minnesotans across the state of Minnesota. And that's a deal that we should not accept. And that's a deal that I'm not interested in accepting for the people of Minnesota. In this last legislature, where we made so much progress for people, I was working with providers across the state to make sure that our hospitals were staffed safely. So I was working with healthcare workers, nurses, licensed practical nurses, registered nurses, nursing assistants, to make sure that there was a standard of staffing in every one of our hospitals, driven by the work of nurses and hospital administrators, a very collaborative approach. We got it all the way through into the last stage of policymaking in the legislature. And one of our large hospitals, the Mayo Corporation, didn't come to me with an objection, but instead showed up in the governor's office and threatened and said, "We will remove up to $4 billion worth of investment in the state of Minnesota if you let this become law." I haven't seen something as blatant as that, but it worked. And over the next number of days, about 10 days at the end of session, the work that we were doing to protect patients in hospitals was unraveled by that threat, and we lost it. We were able to pass just a few iterations of what was a really important piece of legislation because of that dominant corporate threat. It was very frustrating for me. It's very frustrating for people across the state, especially for care providers who know that they are working under very difficult circumstances without enough staff and is putting patients at risk. And we continue to see that in the outcome data. But despite that, Mayo was successful in derailing a patient safety provision, not just for their facility, but for all the hospitals across the state of Minnesota. A number of years ago, as that same corporation began to consolidate its power by buying small rural hospitals in the southeastern part of the state, they purchased a number of those hospitals and then started closing them, including one in a small rural community called Albert Lea. There is just a shadow of what had been a thriving hospital in a rural community in the southern part of the state. That happened in 2017, and there was a commitment on the part of that corporation to make sure that the people in that community got care. 2 weekends ago, I was down in that community again for a listening session filled with people from that community sharing their stories about how they have been essentially abandoned by that corporation, by Mayo, which we rest our laurels on in Minnesota. The Mayo Hospital is a driver of innovation. It is an important part of our state's economy and a leader in healthcare. And yet the people that live closest to it now can't even get an appointment to get care in any of the Mayo facilities. They're going to Mason City, Iowa, in many cases, to get the care that they need, which is further away than Rochester for many of them. There was a woman who told a story that day who could tell by her own examination that she had a tumor in her breast, but she couldn't get in to get the necessary MRI and evaluation, and it was growing quickly. She kept calling. They kept saying, we don't have an appointment for you. She finally got in to see a general physician in Mason City, Iowa, who said, we are clear that you have a tumor. You need to be seen by a specialist. There was a referral. She finally got in to see a cancer specialist in Rochester at the Mayo. And that physician said, you should have come to me sooner. The weeks between when you discovered that tumor and now has allowed a fast-growing tumor to threaten your life. Is the value of a significant corporation more important than the value of her life? I don't think so. And as a policymaker, when we see the market drivers that are shutting people out of care, that are closing facilities so you can't have a baby in the northeastern part of the state, or in Hackensack, Minnesota, where people there say we live in a dead zone because if we have a heart attack here, we're not going to get the care that we need. Policymakers here in Minnesota need to use the tools that we're going to talk about today and more to rebalance the power of a corporate marketplace that is crowding out the very care that we are delivering, promising, and paying for in the state of Minnesota. It is no longer a healthcare system that you can count on. It is no longer a healthcare system that is reliable. And that is not good enough in Minnesota, nor should it be good enough for any part of this country while we're watching these entities, insurance companies, pharmaceutical companies, and our big hospitals making a lot of money and families paying an exorbitant amount of their budgets to pay for it, but not getting the care that they need. That is why I am so committed to the work that we're doing here in Minnesota, because what I started with as a baby organizer so many years ago was a healthcare system that was committed to the health and well-being of Minnesotans. And it's been replaced by a corporate system that's committed to its bottom line at people's expense. That's no good. And we're going to change it in Minnesota. And I'm going to continue to work with this organization and others so we can make that progress and make good on our word. And with that, I'll turn it back to Pat.
Thank you so much, Senator Murphy. Such a powerful story. We really, really appreciate having you here and all the leadership that you've shown in Minnesota, and hopefully other states and other state lawmakers pick up and follow the example you and your state have been setting. So now I'm going to kick it over to our research manager and the author of our state healthcare policy toolkit, Eric Piner. He's going to go through a briefing of the policies we have outlined. There's a bunch of great information in there. We're certainly not going to hit every detail because there's a lot. So please pick up a copy of the toolkit and also just send us any questions you have afterwards. But on that note, we don't want this just to be a one-way street of Eric just talking at you for the next 35 minutes. Please ask questions in the chat on YouTube and either Eric or I will get you some answers. I'm going to use my judgment about having questions come during a particular section if they make sense, or maybe saving them for the end. So if I don't ask your question right away, please don't worry, we'll still probably get to it. And with that, Eric, over to you.
Thanks, Pat. Hi, everyone. I'm Eric Kiner, the research manager at the American Economic Liberties Project. With all the important issues that we've already heard about from Senator Murphy, I want to walk through some of the policy options available to state lawmakers that we present in our toolkit. I'm going to warn you, as Pat said, there's a lot to get through here, so this is necessarily going to be summarized, but I'm more than happy to answer questions or follow up later. So just to break this down in general, I'm going to talk through each of these in a couple categories. The first is issues of hospitals and hospital consolidation in particular. Second is pharmacy benefit managers, or PBMs, which are middleman companies that have a large amount of control over the drug supply chain in the United States. Third is the general trend of the corporatization of healthcare, where the ownership of healthcare practices and care has moved from healthcare professionals towards for-profit entities. Fourth are some issues particularly relevant to labor and healthcare workers. And lastly, I'm going to discuss a couple options for more direct public intervention into care provision. So with that general outline, I'm just going to start with hospitals. Consolidated hospital systems have an extraordinary amount of pricing power over patients and insurance companies and other payers. They avoid competition through mergers and regulatory loopholes. They charge outrageous prices through the monopoly power that they gain in this way. And then they hide those prices through opaque billing practices that many of us as patients have probably experienced. So to address these problems, we present a couple options. The first is simply to enhance merger enforcement against hospital mergers. Hospital mergers often, and research has demonstrated, they lead to higher prices. Merging hospital systems often cut back on care or close entire care departments, and communities end up either without hospitals in their entirety or without particular necessary medical services that they need. So those two things that we propose are important for a state antitrust law to enforce against hospital mergers. The first is, in addition to standard antitrust laws, which block mergers that reduce competition, is to add a standard of care requirement. So the state attorney general can make a determination that the standard of care for the community will be reduced from a hospital merger and block it on those grounds. The second one is a matter of merger notification. As of right now, only very, very large mergers are notified to the federal government so that enforcers can review them to see if there are harms. And they are not even allowed to share the information about those mergers with state enforcers like state attorney generals, who are attorneys general, who are likely to care in particular about hospital mergers. So state antitrust laws should be enhanced to require that any and all healthcare mergers and acquisitions are reported to state attorneys general so that they can review whether those are harmful or not. The Washington Keep Our Care Act, which is a proposed piece of legislation, is a pretty good example of this. Second is the issue of price transparency. We've all seen it. We go to a hospital, we get a bill, and we have no idea where they got any of those numbers from. And this is somewhat intentional on the part of healthcare systems. It should be required that hospitals simply put up in a very publicly accessible way on a website that the public or public interest groups can go look and see and compare prices between hospitals. Indiana Senate Bill 5 does this relatively well and lays out pretty clear standards for those requirements. The next two that we propose for hospitals are two regulatory sort of loopholes that are very common in the United States. The first are certificate of public advantage laws, which we say should be repealed. These exist in 18 states. They are a procedure by which when two hospital systems are looking to merge, they can apply to the state government to get an exemption from federal antitrust laws on the argument that the merged hospital system will be more efficient, provide better patient care. There's no research to back this up, and everything indicates that hospitals that are approved under COPA laws are just as harmful as hospital mergers more generally. And so these should simply be done away with. The next is another regulatory loophole at the state level that allows hospitals to do something similar, and these are certificate of need laws. This is a procedure that requires, whenever a healthcare provider is looking to open or expand new facilities, like say open a new hospital and do the construction required, they have to go get approval from the state government to undertake that construction. These are more common. 35 states have them, and it dates from the 1970s, when there was a belief in the overcapacity of the American healthcare system and providing too much care too easily. The 1974 National Health Planning and Resources Development Act actually withheld federal funding for states that did not pass these laws. The problem is, in practice, incumbent hospital and healthcare systems end up abusing this regulatory system to block the construction of new care facilities so that they can keep their prices high, they can limit their own spending on care. Last thing for hospitals is a more direct intervention onto the problem of high prices, and that is to have the state government set standard rates for hospital services. This is, as Senator Murphy mentioned, something akin to an all-payer system that would require a Medicare waiver. Maryland is a very good example where they had an independent board or commission set standard rates for a range of hospital services that hospitals have to abide in the state. This saved $1.4 billion over its first 5 years. Montana in 2016 had a similar system where they pegged hospital billing rates to 234% of Medicare reimbursements, which also reined in the out-of-control costs of hospitals in the state. Okay, that's hospitals and hospital consolidation, and I promise I'm going to keep going through this, and I know this is a lot. So the second is pharmacy benefit managers, or PBMs. PBMs are middlemen in our healthcare system who represent your health insurance company to decide which drugs your health insurance plan will cover, and then negotiate that with drug manufacturers. While there are a whole host of problems with PBMs, here I'm mostly going to highlight two that state lawmakers can address. The first is that PBMs are paid rebates by drug manufacturers, which PBMs often pocket themselves as a source of profit rather than passing on. And that system of rebates often incentivizes PBMs to select more expensive drugs for you to have covered by your insurance rather than cheap generics that should, cost you a couple bucks. Second, from the rebate issue is that since the three largest PBMs, which control about 80% of the market, own their own pharmacies, this is OptumRx, CVS Caremark, and Express Scripts, these three companies pursue a variety of predatory tactics to disadvantage independent pharmacies and put them out of business. To tackle each of those problems, with the first, states are able to simply require that PBMs pass through all their rebates to the patient buying the drugs. So when you go to a pharmacy counter, if your PBM or your health insurance company was receiving rebates from the PBM, you have to get a discount right there. West Virginia has a law doing this, HB 2263, that simply requires that rebates be passed through at point of sale. That's a relatively simple solution to that problem that states can act on. Next, I'm going to turn to the more general games that PBMs play relative to independent pharmacies. So another proposal is to prohibit spread pricing. And this is going to sound a little complicated, and that's because it is, and I think that's by design from the PBM business model. PBMs sometimes call this differential or risk mitigation pricing, though I will say I don't know that those are illuminating as to what's going on. So when you go to a pharmacy and you buy a drug, the pharmacy is reimbursed by the PBM a certain amount, and the PBM will then sometimes go around to your insurance company and charge them more money than they reimburse to the pharmacy, and then take that difference and pocket it as a profit. This games a number of state Medicaid billing systems to limit the amount of money that the state government has to spend on their Medicaid program. But it's also quite simply PBMs should just be paid by the insurance company a standard administrative fee because they are a middleman in the healthcare system generally. Next, I'm going to quickly run through 4 important policies that can be passed to prevent PBMs from predating on independent pharmacies. So first is you can set minimum reimbursement rates for independent pharmacies. PBMs often under-reimburse independent pharmacies when they are covering them through health insurance. They actually reimburse them less than the cost of the drugs being acquired. So your pharmacy might be taking a loss to fill your prescription. You can set standard reimbursement rates and tie them to National Average Drug Acquisition Cost, or NADAC, which is a database maintained by the Centers for Medicare and Medicaid Services. It's pretty accurate. The next is you can simply require that PBMs offer similar or the same reimbursement rates to independent and their own pharmacies. PBMs often give better terms to their own or affiliated pharmacies and in order to put independents out of business or at a disadvantage. Next, you can also stop PBMs from steering patients towards their own pharmacies. So this actually happens a lot. And as patients, many of us may have experienced this, is that if you are covered by a PBM for your drugs, and then you go to your local pharmacy, you'll discover that your health insurance actually requires that you go to the mail order pharmacy of Optum Rx rather than going to the pharmacy that's down the street and convenient for you. This can be simply prohibited at the state level. And lastly, similarly, you can add a requirement at the state level that any pharmacy that meets the minimum requirements of a plan be included in the PBM's plan to prohibit them from doing these sorts of steering practices. Last thing before I get off of PBMs is that all of those potential requirements that you can add for PBMs don't necessarily mean much if you don't have strong enforcement mechanisms. And PBMs have been very aggressive at fighting against state legislation to regulate them for decades. State governments can add enforcement oversight to the State Insurance Commission to give all of these things teeth. That allows the State Insurance Commission to actually pull their certificate if they violate any of these rules. Oklahoma's 2019 Patients' Right to Pharmacy Choice Act is a very good example of this sort of oversight. Okay, that's PBMs. Now we're going to go on to the third area. And again, I know this is a lot. And so third is the corporate practice of medicine. In the last 2 decades, as Senator Murphy alluded, in particular, there's been a rapid consolidation of the healthcare system under new corporate owners. This can be private equity, price gouging patients and ruthlessly cutting costs and spending on care, or big medicine giants like United Health Group buying up physicians' practices. And this is a really big problem because those new corporate owners are often focused on profit opportunities at the expense of the professional and care obligations that healthcare professionals have. So there's 3 main policy proposals that we would advocate for. And the first is the broadest, and simply to enact, enforce, and strengthen corporate practice of medicine laws. Most states in the United States have laws that require that medical practices are owned, operated, and managed by a licensed medical professional. Unfortunately, for a long time now, there's a range of loopholes that has allowed private equity and large corporate health systems to get around this, usually by finding a friendly physician system, medical professional who is simply friendly to the corporate owner, and then having actual control over the medical practice with a physician management company or management services organization. These loopholes can be closed so that medical services are provided by medical professionals. Next is we would propose that state governments can simply limit private equity investments in healthcare. I think many of us have heard the stories of private equity taking over nursing homes or emergency care facilities and just ruthlessly cutting costs, ruthlessly not providing the care that they're obligated to, billing government benefit systems for care that they did not provide. And this can be limited. So as an example, California several years ago proposed SB 977, which was a proposal to require that any transfer of healthcare facilities or practices to, from, or between private equity companies would have to be approved by the state attorney general. Lastly, and this is returning slightly to the pharmacy issue, is that it's possible to also at the same time require local pharmacy ownership. So I think many of us, depending on what part of the country we live in, are used to pharmacies being CVS or Walgreens or Rite Aid, whereas it's possible to simply require that pharmacies are owned by licensed pharmacists. And North Dakota has done this for a long time. And this would also pull control of the healthcare system outside of the corporate world. Okay, next and fourth, I'm going to turn to issues about healthcare and labor. As we all saw during the pandemic, healthcare workers continue to prioritize patient care despite often being underpaid and overworked. Healthcare being such a big sector in the United States, this represents almost 10% of the American workforce, most of which being direct care roles, with nurses alone making up about 1 in 5 healthcare workers. And personally, having shattered a bone in my wrist yesterday, apparently, I can appreciate the care, patience, and dedication of healthcare professionals in doing what they do. Several policy options that we would put forth here. The first is a standard strengthening of antitrust enforcement for monopsony power. Hospital systems, healthcare systems, et cetera, are often one of the only or the main employers of healthcare workers in a given region. And this gives them a lot of power over workers. state antitrust laws can be strengthened to include an abusive dominance standard that lays out a range of practices that are just presumptively illegal for a dominant employer to undertake, whether that's abusive contracts like non-compete agreements or stay or pays, or other practices that would indicate immediately that the employer has an unfair leverage and bargaining position over their workers. Second is that states can strengthen healthcare workers' rights to organize. Healthcare facilities are often funded by or on land that is owned by the state's government. And on that basis, states can require labor peace laws to mandate that those employers respect workers' right to organize. So they are committed by virtue of being government funded to give labor organizers access to the work site, and that they will not interfere with union elections or labor organizing. And the last thing on the labor front that we propose, and that I think many of us may have heard of, is to simply ban non-compete agreements, which are very common in healthcare. As some of you may have heard, the Federal Trade Commission at the federal level has recently proposed a rule to ban non-competes across the entire American economy. Unfortunately, the Federal Trade Commission might not necessarily have power over nonprofit employers, which is a large swath of large healthcare systems. Likewise, there are a range of effective non-compete agreements like training repayment agreement provisions, which require employees to pay back their employer for training costs if they leave for another job. Now, the problem with all of these is they keep an employee stuck in a job that may be substandard, there may be safety risks, there may be health risks for patients, and that those employees are unwilling to speak out about those problems, they're underpaid and unwilling to go to get a better job, and these agreements should be prohibited across the board. California's AB 747 is a pretty good example of a ban on non-compete agreements that's currently being under consideration in California. Last thing before I finish out are a couple options for more direct public provision of healthcare. Even as more competition in healthcare would result in many benefits for patients and workers, there are areas where more direct public intervention can supplement these efforts. The first is states can implement a public insurance option. So as many of us remember from 15 years ago, when the ACA was being negotiated, there was a consideration of including a public option. Some states have done this. So Washington in 2019, Nevada and Colorado in 2021, and Minnesota just this year. This can serve as a couple important purposes. First, the public option can serve as a reliable option for health coverage for residents of that state. No insurance games, no denial games, etc. At the same time, by having the existence of a public option for insurance, this can be a discipline on private insurers who will lose patients if they provide substandard care or coverage. Turning to the very last policy is an option of public drug manufacturing. So many drugs that are off patent, that have been around for a century, are still outrageously expensive. And the example we would point to here of a state that has taken action on this is that California recently signed a contract with the nonprofit Civica to directly manufacture insulin. This hopefully, like the public insurance option, has the effect of disciplining private manufacturers. If a state steps in to directly manufacture a drug that's off patent, hopefully that will also force private manufacturers to lower their prices at the same time. Okay. That was a whirlwind of a ton of different policy options, and I know that they were extremely summarized across the board, but I hope this gives a general flavor of the sorts of things we're advocating. I'm going to close out there, and I do not know why my screen got extremely blurry there. Apologies. I'm more than happy to take any questions. We encourage you to read the full toolkit on our website, and please reach out to us with any further questions or support.
Thanks, Eric. And we definitely did get some questions. So we're going to go through them in the time we have left. Some of these came in the chat. Some of them came in, were submitted ahead of time. So I'm going to start here. And this question comes from our very good friend, JD Schulten out in Iowa. Iowa lost 1 in 20 pharmacies between 2018 and 2020. What can we do so that we don't end up with only national chains in large cities?
So to go back to some of the PBM proposals I mentioned, there's like varying levels of action that can be taken. So the most direct is actually the last one I mentioned, which is you can simply require direct pharmacist ownership of pharmacies. That's probably a pretty drastic step, but the other policy options I mentioned will prevent PBMs from putting many of those independent pharmacies out of business. No patient steering, no under-reimbursing independent pharmacies, and including all payer requirements such that independent pharmacies can remain within the insurance-covered world.
All right, this one is from the hospital bucket. We're increasingly seeing proposed hospital mergers that cross state lines. Can you talk more about why these cross-market mergers are concerning and what states can do about them?
Yeah, so I think when most people hear about hospital mergers, they think two that are down the street from each other, they compete with each other, and thus when they merge, they can raise their prices or close one of the hospitals. And there is a rising trend in the last 5-10 years of cross-market mergers. And there's a couple really big concerns about these. One is that it can serve as a way of regulatory arbitrage. So a hospital in two adjacent states can merge and pick which state they'd rather have regulatory oversight over or regulatory oversight from. That's concerning on its own terms. Second, and more generally, is that hospitals often want to merge to gain negotiating power against the insurance company that's paying them. So if two hospitals, even in two different regions, have the same insurance company who's trying to keep their prices down, they will merge and then make up a larger share of that insurance company's business and use that power to negotiate for higher prices for healthcare. And that's one of the main reasons why these cross-market mergers are so concerning, because they do increase healthcare costs over time.
All right, here's another one from the chat. Are any/most/all of these wonderful policy recommendations potentially implemented at the federal level?
Oh, good question. I'd probably need to go through each of those line by line to think through each of them. Some of them are not implementable at the federal level. And some of them wouldn't be practicable at the federal level. Just looking through a couple on my list here. The federal government actually is opposed to some of these. So certificate of need and COPA laws, so the certificate of public advantage for hospital and hospital mergers, federal agencies actually oppose these rules. COPA laws are an exemption from Federal Trade Commission enforcement, and the FTC has long advocated that they be eliminated. At the same time, some of the strengthening of merger enforcement at the state level is important to do at the state level, because individual hospitals merging in a given state is likely to not provoke as much opposition from federal enforcers. And it's at some level makes sense for the state government, who's much more invested in the concrete costs of losing a hospital, than a distant enforcer in Washington, who doesn't necessarily have the resources and is also covering many, many other sectors. But if there are specific questions about that, I can go down. It's just a long list of policies, and many of them have their own individual answers.
All right, you touched on this a little bit, but I actually think it's worth going back to. Do you have info on VCs? And I think we'll lump private equity in there with them, purchasing physician practices, especially anesthesia and emergency doctors groups. And yeah, this is definitely something that we've seen a lot happening at the state level, but can you just kind of reinforce what sort of steps states should take if they're seeing those sort of low-level healthcare facility roll-ups?
Yeah, so it's actually a very large problem in healthcare, and it's a really big policy problem, is that private equity in particular has gotten very good at doing these small serial acquisitions where they buy one practice and then another, and they're all very small acquisitions. And they're very unlikely to necessarily get the attention of enforcers, either at the state or the federal level, even though that's starting to change. For example, the Federal Trade Commission recently filed against anesthesia partners, I'm forgetting the company name, pardon, in Texas, who had a decades-long practice of rolling up the entire industry in the state. But this is one of the reasons why, emphatically, in our proposals for strengthening merger enforcement, we advocate that every single healthcare acquisition be reported to the Attorney General, because often this consolidation of either specialty practices or physicians' practices happens through a chain of many, many, many tiny acquisitions. And unless there are notification requirements of many of those, it's quite possible that no one notices before it's too late or before the company's already gotten an outsized amount of.
All right, we have another question on hospitals, and I'm going to add a little bit onto it because I think it's an important point to talk about. Our major hospital systems claimed they were running out of money during COVID, but now all have embarked on large campus expansions. Is this happening in other states? And I'm going to answer from my experience out there and say, yes, absolutely, 100%. We see it all the time. But I think there's an important point here that I'm going to toss over to Eric, which is that you'll especially see rural hospitals kind of crying poverty as a reason, and using that as justification for mergers. Can you talk a little bit about the argument that the hospitals use that they can't survive without merging with some other entity?
Yeah, so I can talk about that in general terms and say that it's not just rural hospitals, it's even suburban or sometimes even urban hospitals that often claim that they are in a terrible financial position and a merger will rescue them from those financial dire straits. And as just a general fact, there isn't a whole lot of evidence that that is actually the problem they're facing. I will also probably want to emphasize that this is something that merging companies use in every industry when they're looking to avoid regulatory oversight. It's a very common claim that we're struggling and we're going to go out of business and there are all these jobs will be lost simply to get a merger past regulatory attention. Those claims should be treated very skeptically because they are very rarely the underlying reason for the merger.
All right, this question comes in from Luke Slindy, one of our organization's great friends out in Minnesota. Can you comment on how privatized versions of government healthcare programs such as Medicare Advantage and Medicaid managed care are leading to consolidation in the healthcare industry?
I can very briefly comment on that, and will very separately say stay tuned for some additional research coming out from Economic Liberties in the near future. So as a general matter, Medicare Advantage and other managed care programs tend to overpay the insurance companies that manage them and also give those insurance companies a very large amount of incentive to go buy providers so that then they have some control over the billing practices of the providers that they're reimbursing. The actual systems by which that works depends on whether it's Medicare, Medicaid, et cetera. So there's complications in that, but that would be my general statement of the issue.
All right, I'm going to turn one of the comments in the chat into a question in order to talk about what I think is actually a really important experience. And I'm gonna give Eric a break of about a minute because I'm gonna handle this one. Fat chance of these great ideas getting through in New York State without noisy protests and digging into campaign donations. As someone who has spent the last several years working in and around the New York State legislature, you are correct that it is very, very tough to do anything there. However, I will say that this last year, there was a proposed merger of two hospitals in the Syracuse area, upstate and Crouse. They were applying for, as Eric had pointed out, one of these kind of COPA approved mergers, which would exempt the hospitals from antitrust scrutiny. New York, even though it has never actually used its COPA law, does have one on the books, and these hospitals were asking to use it for the first time. And there was significant community pushback on the deal. There was pushback from the New York Attorney General. There was pushback from legislators at the state level. And the hospitals ended up abandoning the merger, which I think is actually a great outcome for the community because the merger would have been really destructive. So even in places where you think, and it's totally true, the healthcare industry is very powerful and nothing that Eric has laid out today is going to be done like easily or without a fight or without a lot of local organizing and door knocking and pushing on elected leaders to make it happen. But you can, even in those places where you think the politics might not be fantastic for you, still make good things happen in this area. And I think that was a great example of two hospitals thinking that they were going to coast through with a merger and get it approved under a COPA law. And then there was so much pushback that they ended up abandoning the deal. And I think that was actually a really great win for New York and showed that folks do have power to affect change in these areas, even if they don't think they do, right, when one of these deals are announced. On to the next question for Eric. There's been a lot of kind of versions of this question, so I'm just going to kind of try and synthesize it. Wouldn't a state-level single-payer universal health insurance or public options such as Minnesota Care, which is open to all Minnesotans, solve a lot of these issues? And then there have also been folks asking about national single-payer healthcare, and isn't it preferable to do something like that versus all of the bips and boops and stuff that we're talking about today?
Thanks for the very small question, Pat. So I think I would say everybody's on board with universal health coverage, and I don't think anybody, or at least I would advocate for it. I think there is an issue that many of the bits and boops that we outline in the policy toolkit are still necessary. Private healthcare providers, drug manufacturers, et cetera, are very powerful, and they will still have a huge amount of that power under a single payer healthcare system, which would still have to pay them, negotiate with them, and structure the terms for the provision of care with them. And changing things to a single payer system is not on its own going to resolve those problems. Pharmacy benefit managers would still exist as companies, and they would still be able to do many of the harmful things they do, whether it's to independent pharmacies or whether it's in terms of the drugs that they choose to have covered. So many of these policies are nonetheless still essential. One of the advantages, and as I was sort of outlining with a public insurance option, is that a government plan would have negotiating power with those private entities, but that doesn't supplant the need for sensible rules, laws, and regulations to govern those providers.
All right. I want to say a big thank you to Eric, not only for doing a ton of great work on the toolkit and for answering all the questions big and small today, but for doing it all here on screen with a busted wrist. We hope you feel better and that you are out there helping folks turn these proposals into law sooner rather than later. And with that, I'm going to say my thank you and turn it back over to Nidhi for some next steps and a big goodbye.
Good. Thanks, Pat and Eric. You've got to love how much commitment folks at Economic Liberties have to this issue, that they will voluntarily break their hands so they can go through the healthcare system and bring an authentic voice to today's conversation. So thanks, Eric, for that. Well, thank you everyone for joining us. This is an immensely critical issue, and we're seeing how engaged everyone has been in the chat. And, thank you to Senator Murphy for joining us and sort of laying out the stakes. We have the momentum. And if you've followed along through this workshop with Eric and Pat, there are a lot of ideas in the toolkit, and it's a lot to digest. But as they both said, we here at Economic Liberties are there to support you. And as I said in the beginning, this is our 4th toolkit. And if you go to the Economic Liberties website, you can see other toolkits to take on the corporate subsidy machine in the states, how to challenge big tech at the state and local level, and how to reform antitrust reforms. There's also research and solutions on tackling other issues like junk fees and non-competes. We really want policymakers in all 50 states to take these ideas and put it into law. And we want to amplify the stories of success and lessons learned. So if you're a lawmaker, a local community organization, a labor union, or a business association interested in any of these issues, really anyone watching this, please reach out to us. And thank you for being part of this workshop today. Goodbye, everyone. Have a great Monday.